Well, hello, everyone. Welcome to the 2024 webinar series sponsored by the Association of Neurovascular Clinicians, ANVC. My name is Michelle Whaley, and I will be moderating this session, Tips and Tricks to Making Neurology Fun and Exciting for New Graduates and Experienced Nurses. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-based, evidence-empowered clinicians that fully support the holistic needs of patients and their families because stroke patients deserve nothing less. This series has also been endorsed by the Society of Vascular and Interventional Neurology and Mechanical Thrombectomy 2020. For more information about ANVC, please go to www.anvc.org and become a member. We have a few housekeeping items before we begin. This session will be recorded and available on the members only section on the ANVC website, anvc.org. You will receive one continuing education hour for the live session only. You must attend the entire session to receive credit. After the session's over, you will receive an evaluation from Arizona State University. After you complete the evaluation and return it, you'll receive your CE certificate. Please feel free to enter any questions into the chat throughout the presentation. We'll have time at the end to address questions. I'm proud to introduce our presenters for this webinar, Leah Farrell and Lindsey Boswell. Leah is the Division Specialty Educator for Cardiovascular and Neurology Services for the Continental Division with HCA. She has worked as a neurology nurse for the last 15 years. She started her career as a new graduate on the neurology unit at Swedish Medical Center, and there she worked as a bedside nurse. She was in nursing leadership and was the unit educator. From then, she went on to become an adult gerontology acute care nurse practitioner and was on the staff at Skyridge Medical Center in Lone Tree, Colorado, and really worked to assist with education of nursing staff around stroke quality measures and stroke core measures. Has always been an advocate of the stroke teams within that division of hospitals. From there, now works to provide orientation and educational support opportunities for new and experienced nurses at the 7 facilities in the Denver metro area, and always has had a special focus in neurology in addition to interventional radiology and the cardiovascular lab. Lindsey is the high acuity educator for Swedish and Skyridge and covers the ICU and the progressive care units. She started her career in neurology as well at Swedish, was a bedside nurse, charge nurse, clinical nurse coordinator, transitioned and worked in burn and reconstruction for a little while, and then went on to get her acute adult geriatric acute nurse practitioner. She's worked as an NP in pain management, and then now is back in education because both of these ladies as nurse practitioners really love and live and breathe educating nurses. She works closely with nursing staff, ensuring proper onboarding, growing preceptors, and supporting ongoing education in both the progressive care and the intensive care units. All right, I will hand it over to Leah and Lindsey.
Thank you, Michelle. We're going to advance our slide. Sorry. All right, so thank you so much. My name's Leah Farrell, like she said. So I'm the Division Specialty Educator for Cardiovascular Neuro, and this is Lindsey over here on my left. So thank you so much for coming and listening today. So first off, we want to talk about our disclosures. We do not have anything to disclose for this presentation, neither Lindsey or I. Our objectives here today, we really want to talk about the state of nursing orientation and education as it is, and how we are working to engage our new learners and our nursing coworkers. We also want to talk about how we're using a stage-based orientation process to help with engagement and help with competency level. And then we're going to talk about some alternative options to education and how we can really make it fun for our learners and for our new nurses and how to engage them in different processes. So we're going to kind of talk about all of those things over the next hour. So first off, we wanted to kind of tell you where we're from and kind of what we do. So Michelle gave us a wonderful orientation, but we want to really kind of hone in and tell you what we're all about here at HCA. So we work for the Continental Division of HCA. HCA is an international company that has over 180 some odd hospitals. We work in the Continental Division, which covers Colorado and Kansas. So within the Continental Division, we have 8 major facilities, as well as some other outliers for inpatient rehabs. We have multiple freestanding ERs and urgent cares within that division. We have 2 tertiary care centers within our division. One is Swedish Medical Center in Denver or Inglewood, Colorado, and then one is Wesley Medical Center out in Wichita, Kansas. Those are also our comprehensive stroke centers. And then we have 2 thrombectomy capable certified centers. One is the Medical Center of Aurora out in Aurora, Colorado, and then we have Sky Ridge Medical Center in Lone Tree, Colorado. So we work really closely with these areas. There's a lot of neuroeducation that has to be done within all of these facilities and across state lines. And so we actually utilize a centralized education model for this and for clinical orientation. And what that means is we have a central group of educators. Some of them are stationed at the facilities, some of them are stationed at our division office, but we all work together to utilize our resources and provide education so that we're not, that we're standardizing practices and making sure that we're educating everybody to the same level and expectations. But also it helps us utilize our resources appropriately. We don't have 4 educators doing the same thing when we really could only have 1 educator teaching 4 different facilities the same way. So it really works well for us. We really actually like the centralized model very well. So with that centralized model, we have over 70 educators that are employed just in our division, and that includes Wichita, Kansas. So we have service line educators, which is what I do. So I cover service lines for cardiovascular and neurology service lines. And then we also have facility-based educators. So we have educators within the facility that are, boots on the ground with the staff, learning and seeing what's going on those units and what we really need. And they kind of report up to the service line so that we can standardize our practices across. Now we're using a standard orientation process. It's called a competency-based staged orientation model. So we shorten that to a CBSO because it's kind of a mouthful. So our CBSO model actually, we're going to talk a little bit more about it here in a second, but it's really helping us kind of hone in on our competency of our new nurses in a new way. And it's also utilizing our adult learning theories to kind of help these new learners come in and really hone in on their skills. So for our neurology nurses, they actually get our CBSO, and then we also have specialized neuro classes that they attend to help with the learning and help finalize some of these concepts. So we're going to talk about some of those specialty classes here in a little bit. And then we also make sure that we do annual neuro competencies for all our neuro learners. We want to make sure that they're continuing that education and continuing providing the best care to the patients that we have. So. All right, so first off, we want to talk about our orientation education. So these are when we talk about orientation, we're talking about new graduate nurses coming in. So these are brand new nurses. Some of them have some CNA experience a little bit, but most of them are brand new to the medical field. And so we really are honing in to make sure that we're engaging them and helping them learn through this process. So to start, we're going back to our competency-based staged orientation model. So you can kind of see here that it's a 5-stage process. And it's really a new and innovative way to make sure that we're building on education that we already have or that they already have. So it kind of individualizes education plans for our learners. So if somebody already knows something, we don't have to make them sit through a class to learn it again. We can build on the knowledge they already have and progress them to the next stage. Whereas the person next to them who might not know that concept as well, we can actually sit with them, teach them the concept first before they advance. And so it allows individualized learning plans. It's a great model to help us also identify issues that we're having as they progress on so that we can hone in on that information. So with this model, it starts with stage 0. Stage 0 is kind of setting the stage. This is your very basics of nursing orientation. So getting them in the building, making sure they have all the things they need, like a badge, access to the charting system. They know where their unit is. It seems silly that those would be the things that we had to teach people, but sometimes that gets missed in the orientation process. When they're interviewing from across the country and then they show up and their first time in the building is their first day on the job, we got to make sure they know where they're supposed to go. And so that's stage 0. Stage 1, we start talking about our skill building. So this is kind of identifying what do we need to teach them over the next few weeks or next few months, depending on how long their orientation is. And what skills do they really know really well, and what skills do we need to start identify and give them that extra knowledge. And this is really meant to be stage 1. They're really like hand in hand with their preceptor on the unit or with an educator on the unit. They're never alone at this point in time. So we're really evaluating and identifying those education gaps. Now, stage 2, we start to allow them a little bit more independence. Some of those skill building in stage 1 that they already know, we allow them to start independently performing those skills. Whereas the ones that we have identified that they need more help on, we're starting to really give them the opportunities or the exposure, per se, to those skills. So if they have a neuro patient, but they've never taken care of a neuro patient that received a thrombolytic before, we're going to try to really grab those thrombolytic patients and make sure they're assigned to those nurses, so we can really build those skills until we get to stage 3, where they start. Now we're going to start asking them, okay, so what do you expect with this thrombolytic patient? You've been able to take care of them now with your preceptor. So what are you anticipating? And we start to have that integrative practice of looking ahead and trying to really get them to think about what comes next, or what would the patient might need. So anticipating needs, providing that critical thinking aspect. And in this stage 3, we do give them a critical thinking exercise where they really sit with their preceptor and really hash out with the preceptor of what potential complications could happen. What does a neuro assessment look like on this patient? What deficits do they have? What deficits have gotten better? What kind of side effects might those medications have that their patient's taking? And so that's our stage 3. And then stage 4 is really looking at their independence. So finalizing, are they competent enough to take care of these patients on their own? And then really telling them throughout this whole process where to find their resources, where to look up the information that they need to take care of their patients to the best of their ability. And so once they're done in stage 4, we're really looking at independence at this point so that they can go out and take care of these patients. Now, like I said, through this whole model, we have a guide for our preceptors, and it really helps our less experienced preceptors, which I think we all are dealing with across the country. Is we have less nurses that have been around for 30, 40 years that are taking these new grads in. And so we really have less experienced preceptors. And so this guide can help them really hone in on, they tells them exactly what to do and what to teach their orientee. And then if they're struggling, they can reach out to an educator through our centralized model really easily to come help them teach those pieces. And so this model is great with those newer preceptors and really helping them learn how to teach the orientees. And then on top of that, and the last piece of this is we do have an assessment test. I talked a little bit about the critical thinking exercise that we already have, but we do have an assessment test as well. And so we analyze and have them do an assessment test in stage 1 when they first get there. And then in stage 4, we actually have them repeat that assessment test and look at how much they've progressed, what we still need to hone in on before they're fully independent on their own. And so this model has been great with our new nurses who really don't want to go back to learning something they already know. They don't want, if they really truly understand it, they don't want to spend 20 minutes learning it again. They want to move past it to get to the comprehensive stage of it. And so that adult learning model has really been helpful with our new hires. And so that's our CBSO process. So once they've finalized their CBSO and they've been deemed competent to take care of patients, we really have been working with neurology-based education throughout this, and looking at their patient-specific population. And so if they're taking care of cardiac patients, we can really specialize on the cardiac portion during CBSO. But for the neurology ones, we also can hone in on neurology. So another addition to that is we have given them a neurocares class, is what we call it. And so this is a class that we've provided to all new to neuro nurses. So not just new graduates, but anybody that is an experienced nurse that's new to neurology. As we all know, neurology has its very intricacies, and you need to really know how to do those neuro assessments and look at your patient and really be able to identify those issues. And so what we kind of did is we came together and we looked at what we were missing as a division and what we really wanted to cover in this class that we needed for all 8 facilities. And so the content that we cover in this, we cover neuroanatomy, we cover seizures, brain tumors, strokes, hemorrhagic strokes. We really hone in on core measures and documentation to help with some of our fallouts that we talk about. And we'll talk about that a little more later. NIHSS, we help them with their assessment skills. They do all get NIH certified in this division if they're working with neurology patients, but we look at how to help them really hone those skills in. And then we also have an ICU part of this class that we talk about ICP management, neurointerventional radiology, and interventions that go along with that. And then we talk about dysphagia. And so to make this a very interesting class, we've used a lot of different modalities to maintain that interactive feature. So we do start with some e-learning through our learning module, which we use HealthStream. There's other ones out there, but we use e-learning. And so they actually come in kind of with pre-work where they look at these modules, they kind of get the basis of what we want to look at. And then we start with a little bit of lecture to kind of help hone in some of those e-learning aspects that we have. And then we really break out and start doing some more entertaining stuff. So we use simulation, we use virtual reality. We've built an escape room, which is one of the things that we do. And then we have other games that we play in this class. And so we're going to kind of talk about these different things and how they've engaged our staff members.
Great. So one of the opportunities that we got to be a part of was really fun. We got to coordinate with this virtual reality company who came in, and they were piloting a program for training new nursing staff in critical situations without having to have an actual patient in the critical situation, which was amazing. When we first were introduced to the program, there was a module already built that we got to try out, and it was a simulation of a fire in the OR. And so you put the headset on and you're in the middle of an OR. Everywhere you look, it just feels real and it looks real. And you have other staff members there that you can ask questions to that are interactive. And then there's items for you to do. And so when the fire breaks out, you're right in front of it and you have to actually put your motion into action. So that was really fun. And the one that we really loved was, of course, the neuro one. There was a module that we got to actually give feedback and work closely with them to make it an improved module. And it was all about an NIH assessment. So it took the nurse from the beginning of a full NIH assessment, and they were in the room with the patient. They got to talk to the patient and ask them to do the different tasks, and then the patient would actually do the tasks. And then afterwards, they would score it using the NIH scoring and then get immediate feedback as to why that was correct or why their answer was probably slightly off. This was a lot of fun for us because prior to the virtual reality option, one of us would always play the patient, and it's very hard for us to fake a facial droop and a slur on the right side. And, it gets kind of funny that way. But this whole virtual reality was all the one person got to be engulfed in the entire simulation. So they really liked this one.
All right. So another thing that we do in outside of virtual reality, which they really do love, like Lindsey said, they do like the virtual reality, and that keeps them engaged. We created an escape room, and so this is one of the really engaging pieces that the staff really like. And so we kind of wanted to walk you through our escape room. and kind of tell you how we built it and what how we made it work for the education that we wanted to provide. So it started off, we really just wanted an alternative to kind of keep people engaged. We were really tired of the death by PowerPoint. And really we were losing ideas. And so escape rooms at the time, they're starting to be pretty popular. We were hearing about them a lot. And so we decided we were going to test out and try to make our own. So we did this one as a theme with an ischemic stroke patient. And really what we were trying to hone in on this was we were looking to help with stroke core measures that were being missed in the hospitals, as well as documentation. So we wanted to make sure our patients were really being taken care of the way that they were supposed to, but then also making sure that that documentation piece, which we all know is so important, was getting done correctly as well. So we initially started with a med-surg version, and then we realized we actually had some ICU variability. And so we actually created an ICU version as well. And so depending on the population that we have in the class, we'll either break out the med-surg version or the ICU version. And so we'll kind of talk about that too. So with this, we're able to assess their assessment skills, their critical thinking skills, their documentation knowledge, and then also we can help with our core measure compliance through this. So the first step of our process, we give them the rules first off of what they get. They get a set amount of time within their escape room, but really they're looking for puzzles and pieces. But to do that, we have to kind of send them along a path. And so we really tell them to start with your patient. You're always going to start by assessing your patient. And so with this, you can kind of see in this picture, and the puzzle pieces aren't that visible on a normal day. We wanted to highlight kind of how we did it in this picture, but we put the puzzle pieces on the places on the mannequin where they should be assessing. And so we make sure that we put a puzzle piece like on their back so that they're looking at their skin, on the back of their head so they're assessing for any pressure ulcers on the back of their head. In the ICU version, we have it on an EVD and like where the measurements are. On the fall, we also have them on like the bed alarms. And so it's not just the neuro portion of the assessment, but this patient as a whole that needs those pieces. You have to go in and find the pieces. So we do cap refill, we do groin sites on where we place those puzzle pieces. So they should be assessing those areas with their patient. So once they got all these puzzle pieces together, you can see it created a code for them to go to the next step. So that code led to a box with a lock on it. And that lock led to another core measure that we really wanted to work on. So we were really struggling as a division to get our dysphagia screening documented appropriately and also just understood by the new grad nurses. And so for us, dysphagia screening, we wanted to, it's documented a specific way so we can pull it for data, but also we just wanted to make sure they understood the depths of how this affected their patient. If their patient was silently aspirating or had any aspiration risk, we didn't want to be the reason that we were causing them harm. And so what we did with this piece of our escape room to try to make it more entertaining, we actually gave them different scenarios. And you can see on the picture on the left, there's a scenario about a patient, and then you say whether they would have passed or failed the dysphagia screening. If they pass, it gave a word, or if they fail, it gives them a word. And so then we have 8 different scenarios that they have to go through, and those 8 words actually come up with a sentence. And so, that sentence is the puzzle piece that moves them to the next step of the escape room. And so we used some blacklight ink, which we thought was really fun. And that was actually one of the more fun things that people really love is the blacklight flashlight. And so we actually put numbers on the corner of the scenario so that they know which order to put the words in to create the sentence, because otherwise it's just garbled. And so and they do have to create or pick the right one. If you pick pass to get the right word, if you pick fail, it messes up your whole sentence. And so they do have to really think about it. One of the things we do in the escape room is if they get stuck or if they have questions, we do try to help them along. And so they get a certain number of hints as they're doing it. And their goal is to get out of the room within 30 minutes. So you can kind of see on these pictures how we did that. We thought that this piece was really fun. And this actually took a lot of, we were trying to make it interesting. And so this is what we we really came up with, and that they do really enjoy this part of the escape room.
So this part moves us into the vital signs section. This is really important, as we know, for core measures and making sure that their vital signs are actually done on time and that they're within parameters. And so we have different options for them to choose between which one would be correct for this patient. So the learners need to identify what information was provided to them relating to this patient, and they needed to pay attention to the current orders that we have available in the room for them and the times. And so just by looking at the times, they can rule out a couple of them. And then by looking at the orders, the current orders compared to the previous orders, they'll know which blood pressure may be out of parameters. This one in particular is actually fun. It causes a lot of dialogue in the last couple months because we had a unit in a facility that didn't typically take neuro patients, and they began to. That was part of their transition to taking neuro patients. And so the staff began coming to our class to get them up to speed on neuro patients. And one of the things that they were all very vocal about was that they understood why NIHs had to be within that 4-hour time limit if the parameter said 4 hours. If it was a minute later, that is a fallout for us. And so they were able to verbalize that, but they didn't know almost entirely, that whole unit didn't realize that vital signs was also important to the Joint Commission as well. I mean, they knew that they had to do it by the 4 hours, but they didn't realize that 2 minutes late would be a ding. And so this created a lot of dialogue for us that we could talk about in debrief, and then we were able to see that gap and close it relatively quickly. So that one was pretty cool. So then they put that on the wall, and it sends them to the next section, which is patient education. The same type of thing, we give them 4 different options for patient education. As a HCA facility, we use the Meditech for charting, and so we just pulled that exact screen that they would see when they chart, and we put different options in there for patient education. We really wanted to focus on the core measures for sure, and then also what was specific to the patient. We often find that they'll just put in any kind of education that works for stroke factors, like smoking, even if they're not a smoking patient. If they're non-smoking, then they don't need to really focus on that, right? And so that was kind of the thing that we wanted them to personalize it to the patient and make it important to them. There's also discharge education that we have in the same screen. And we really wanted to emphasize that because we found that there was a lot of fallouts related to discharge education specifically because it was just left blank a lot. And so we really focus in on that area and talk about that throughout the course and then the debrief. And so then they put that on the board as well, and it brings them to the next clue, which is discharge medications. And so they're finally getting the patient through, they're sending them home, and now they need to do the med rec. And a lot of times we will go in to do a chart audit, and there won't be anything in the chart, or it'll only say that they printed out the sheet as is, and it doesn't show when the patient is supposed to have their next dose. And so it really makes them look at everything. There's some options that are maybe missing a medication, and so they need to be able to catch that. They also need to make sure that all the medications on the list are actually the correct medication and the correct dose and the correct number of times they take it that day. And so they have to be diligent about looking at the orders and cross-checking that with the discharge order. And then the last piece is that they will handwrite, which we handwrote and laminated these, but they need to be handwriting when the next dose is due. And so we had different options of that. Some of them were correct, or one was correct, and then some of them were wrong. So that guides them to hang the correct one on the wall. And then all 3 of those together, as you see on the right side of the screen, gives you the escape room code. So there's Leah and I pretending to escape our neuro challenge. This is such a great scenario. We always get a lot of interaction, especially from those who are really quiet in the room at the beginning of the class. It may be a class where nobody wants to talk and nobody wants to interact, and you're really trying to get them to be involved. And then we get them in this scenario and they all kind of spark up. So it's been really fun to be a part of.
A lot of those ones that really are quiet really actually enjoy the puzzle parts of this. And so you'll see them kind of going off in the room and doing and learning different things. And then you'll start to see them really engage in that conversation. And so pulling them into that is really great. And so, so those are the pieces for the med surge. One, we also have the ICU variation, like I told you, and this picture has a lot of people in this room. There's not normally that many people, but the other things that we added to the ICU variation is instead of doing the discharge medication reconciliation, the ICU is not discharging a lot of our stroke patients. They're usually transferring them out. And so we changed that step to include EVD management or ICP management. And so we had questions about what the normal ICP is or what medications can be used to reduce ICP. So we have like a mannitol question in there or a hypertonic saline question. And so we were able to use the same basis, but we just changed some of the questions around and what they're looking for. And it still progresses through really well. And at the end of this scenario, they if they escape the room, they actually save the patient from having to go to the OR to get a hemicranie. And so it's really a cool variation of it that we were able to do. It still includes the documentation and the core measures piece and the dysphagia screening piece, because that is important no matter what unit they're on. And so they really enjoy that. So that's our escape room that we do. The other thing that we do we have other things that we can do in our neurocares class. So and we actually switch them up. We don't use the same game every class. And so it helps keep the class engaging as well. But we've taken a lot of kids' games that we played as kids, and we actually made them into educational opportunities. So there's a ton of pictures on this slide, but we do heads up, where we actually get cards with a name on it, and then we hold it up, and the other person has to describe what it is. So we have a variation of that for neuro. We have one for trauma. And so it really kind of helps us assess whether they actually understand the concept. Because if we see them skipping the same card all the time, we realize we really need to hone in some education on that piece. Maybe it's the, triad of death for trauma. And so we really want to hone in on those pieces of the triad of death. Something like that. Or, and so heads up is really fun and it's very quick. So you can do it when you need space filler too. If waiting for the next speaker to come or the next person, you can actually use these games pretty easily. So we also do a version of Jeopardy at the end, and that kind of helps us. We give them buzzers that make noises, and they get really into scoring. We can use an app actually to have them buzz in sometimes, and so they can see how fast they're doing and whether it was right or not. We have other electronic games that we can use that are companies like we have Slido that we can put into PowerPoints, or we have other ones that we can use. So we do those. Mystery diagnosis is a game that we kind of came up with where we actually give them a diagnosis, and then we give them 5 or 6 diagnoses, and then we give them a bunch of cards with symptoms or tests on them, and then they have to actually categorize them. So it's this picture here with the pink cards. But basically, like if I give them a card that says Guillain-Barré, then they have to pull out all the cards in their pile things that might attach to that. So it might be an autoimmune disorder, or it might say something that progress weakness, airway issues, and so they can actually kind of look at that diagnosis, and then we can analyze whether they actually understand what that diagnosis looks like. We've made a clue game, which is really fun. This one in the picture is for a hemodynamics clue game. But we come up with characters, and then they have to answer questions to figure out who is the murderer and what weapon they used. So when that one's really fun. We have pin the symptom on the brain. So this one was a late night, something where we really we were actually trying to pull in our neuroanatomy conversations. Because in our neuroanatomy stuff, we talk about what symptoms patients will have in what areas of the brain. And so then we decided, you know what, it'd be kind of funny if they just had to go up and pin it, like point out where it's at and point out where Broca's area is, point out where Wernicke's is. And so we actually give them these little pieces and they go in and they stick them on the area of the brain. And so sometimes it's things like sensory deficit, and then we want them to go point it at the parietal lobe. And so it actually helps them hone in some of the information that they have. And it's kind of fun. Sometimes they look at us like we're crazy and they don't know what it is. And so, so we can hone in some of those conversations too. We do case studies. We actually made Pictionary, which is really fun. There's these bingo cards. This one's a pediatric neuro bingo card. And so this is used in our pediatric neuro lecture, and so basically it's like as things are talked about throughout the day, they start to identify them on their bingo card, and then whoever gets the bingo wins. And so it helps them engage in the PowerPoint lectures that are a little bit less fun. And so it gives them something to do for that. And then we also have a self-learning station. And so with this one, we actually set it up on a unit. They can use it in their own time. But then these are the dysphagia scenarios actually that we use in our class. And so they really read the scenario, they look if they pass or fail, and they can actually lift the card up, and then it'll just tell them the answer. And so they can look at it whenever they have time, which is kind of fun. So they engage with that a little bit on their own time. So that's kind of what we do with the new grads. So now we want to talk about ongoing education that we have after they've gone through orientation and after they've received this initial education. So all of these things can continue on. So they can always come back to the neuro class if they ever want to. We're never going to tell somebody, no, you can't come, you already came. We will let them come, 10 times if they really want to. But we do have some ongoing education as well.
So one of the things that we have implemented on neuro was initially when I started about 10 years ago as a new nurse, the neuro unit had already established these multidisciplinary rounds. And this was probably one of the best things that I could have been a part of as a new nurse, learning to understand my stroke patients and what was really happening with them. They were really done well on our unit. They were done in the patient room with the entire group there to talk all at one time. And so it took a lot of buy-in from all of the different disciplines, but when it worked really well. Some of the team members that we had were, of course, nursing. The neurology team was there, stroke coordinators and the APNs that were part of that group were there, pharmacy. The therapy team would come, especially if they were needed for that patient's physical therapy moving forward or occupational therapy. Case management was always there as well. The medical team was always invited, but they often couldn't make the same time. So when they could come, they would come. And then, of course, we would move from one end of the unit. We'd start at one end and we would move all the way down. And so the whole group would gather at the end of the hall. The nurse would prepare their stroke patients in advance. If you see the two documents there, the S bar is on the back. That's the form that we would use for nurse-to-nurse handoff for all of our patients on that unit. And we would just make updates and then hand it off per each shift. Well, every stroke patient had an option on the back for essentially a script that they would read or present during stroke rounds. The script was written out for them and they just had to fill in the blank related to the patient's diagnosis, the medications or orders that they're on, the treatment plan and the discharge plan, and then any therapy components that were needed. And this included all of the stroke core measures. So we really hit all of those things in one script that took me maybe 2 minutes to say in the group setting in front of the patient and the family. And it went really fast and smooth, and it got the information to everybody all at once. The best part about this was the availability of the team. For example, if a medication needed to be changed and we were all talking about it, the neurologist decided they wanted to stop something or add something. Pharmacy was there with their computer and would do it right then in the moment. We could clean up orders if there happened to be two contradicting vital sign orders because they maybe transferred last night from the ICU. Whatever the reason may be, we could clean up those orders and make sure we were following the right ones. This was also a really wanted time for the family. They got really used to having these rounds on the floor, and they would come specifically in the morning for this. They would plan their mornings around it. And so they would often come to us and say, hey, are they doing rounds today? So it really was a great part of my education as a nurse. I got to listen to the way that the neurologists or the stroke coordinators explain different ideas to the patient and to the family. And then I was there firsthand, and I could reinforce what they said when inevitably they asked the nurses later on in the day, well, what did the doctor mean? And so it really incorporates the bedside nurse and makes them take ownership in their own practice. And I think that this was probably my favorite piece of being a neuro nurse, was multidisciplinary rounds. Leah was actually there when they started this on that unit.
Yeah, so Michelle actually, who's moderating, also was a big part of this. So, but a big piece of this was engaging the staff. And so the whole point was we were going for a comprehensive stroke center at the time, and we needed the staff to really understand what they needed to say to a surveyor if they were to come in and ask. And we wanted them to really understand the patients. And so it started as a way to help them get that information easily. Well, then it turned into just an engaging overall process. So there were some nurses every day that were like, oh no, I have to do rounds, and they would get nervous. But after about the third time, they really were ready, and they felt like they were learning all the time. And so I still, to this day, when I see rounds in the ICU and different places, I still learn something all the time. And so it helps keep that engagement with the staff. They become a team, so they're working together, and so that helps engage them as well. And so it's really and it helps them just learn how to read their orders and how to make sure they know what the treatment plan is. In the day and age post COVID, we've seen a lot of nurses that have kind of it's different because the staff ratios are a little bit higher, and the skills are a little bit more intense. And so having them understand really how to read an order, what they're really supposed to be doing, understanding the diagnosis, it saves them time in the end. And so it seems like it's more time intensive to do these rounds, but in the end, it saves everybody more time. So it really engages our staff with this. So this is one of the ways that we use to help teach and also help identify learning gaps so that we can come in and then do other forms of education outside of it. If somebody's really struggling on the same thing all the time, we can actually identify that during rounds. So this is one of the things we use. We also use some other forms of education as well.
Well, this one came about because in the education role, we of course love neuro, and so we both round on the neuro units when we can together often. And we realized that the nurses on the unit, even the most experienced nurses on the unit, still had questions about the patients that they were seeing in lifetime. So they would come to us weekly, at least, with, oh, we saw this new patient and this happened. Why did this happen? So we coordinated with the stroke coordinators at that facility, and we all kind of got together and decided to do a lunch and learn. And once a week at the same time, on the same day every week, we would all come together, and all the nurses that were on shift would usually come and bring their lunch, and then we'd sit there and eat while we learned about neuro. Sometimes what that looked like was we would bring something from education that we noticed a trend on the unit, or the stroke coordinators would see something that they felt they wanted to bring to the nursing staff. But oftentimes it was driven by the nurses and what they wanted to talk about. And it was usually specific to the patients on the unit. And so the biggest challenge we had with this was trying to get it available to more people, because it didn't matter what time we did. The only people who could come really were the ones working that day. Nobody came in for a 20-minute lunch and learn. And so what we decided to do was we recorded them and we put them on a platform that required the nurse to put in their employee ID and password. So it was still confidential. And then we also didn't use any patient identifiers during the session. We just talked about room numbers. And so it allowed us to really dive in deep in one patient, and everybody on that unit that listened to this particular lunch and learn would be able to see or know which patient we were talking about just by the room number. And then the stroke coordinators would often pull up the imaging associated with that patient and then go through that with the nurses, which that was probably the biggest fan favorite because the nurses always love to see that and understand a little bit more about the imaging.
Yeah, we were able to QR code those recordings, which was really cool. And so then we were able to post those around the unit. So you could walk in, they could scan the QR code, and there would just be a list of all the lunch and learns. And so that if they were sitting on their lunch and they wanted to listen while they were eating, they could, or they could, if it was something specific that they had a patient and they're like, oh, I know we talked about this in the lunch and learn, they could scan that QR code real easily and then go and quickly review it. And so QR codes actually have become a very good educational tool for us to give really quick information for things like new devices. If you have a new piece of equipment that's on the unit, you can actually throw a QR code on it real quick and have the video, the informational video that takes 30 seconds for them to listen to in case they miss the in-service or things like that. And so it's actually QR codes are seem to be the way of the future these days, so it's very helpful. So, and then the last thing we kind of use to engage our staff, and I can't take full credit for all of these. Michelle Whaley actually helped with a lot of these as well. These are the clock in these pictures are her brainchild. So, but we do want to incentivize some healthy competition. We all get a little competitive, I feel like here and there. And so some of the things we help to engage our staff was really kind of getting goals and metrics met. So we use this with the T&K door to needle stuff or TPA door to needle times. We wanted people to really fight to have the best time and to do it safely. And so that includes documenting it correctly, providing safe patient care, and doing it fast. And so when we had these quick times, we would go in and we would take their picture, we would plaster it on social media with their permission, of course. But then we also had kind of a board in the ER that had like the Hall of Fame kind of. There's one that looked like a bullseye that we used at Skyridge, where the fastest time was in the center, and then we had slower times progressing out. But then we also had the leaderboard of EMS. We also engaged our EMS components with this because their names got put onto a board in their EMS lounge as well. And so incentivizing those goals and those metrics and giving them something that is special. It doesn't have to be big. It can really be something very little. So some of the things that we have used is we had brain pins that they could put on their badge if they reached a certain goal. There's challenge coins out there if they do really great times or special things. We have stickers. We have sometimes we have even things like water bottles and like swag. We basically get swag and we start to hand it out. But sometimes you'll hear people come up and be like, wait, how come they got a pin and I didn't? And so it helps that engaging in that healthy competition so that we can really engage our learners. And then we can even incentivize things like, well, how many in-services have you attended this year? And once you hit a certain number of in-services, we give you something to help them engage in the other education on the unit as well. So trying to make it fun and quick and entertaining for them, because that is a big thing. Making it quick is very helpful in this day and age and engaging them. So in conclusion, and this is just some other fun things we've done over the time, we have therapy horses and therapy goats that come in sometimes. This is just in the hospital and us being kind of silly. But in conclusion, we use a multimodal approach. You cannot use the same method all the time for every learner. It doesn't work. You have to have different things for different people. And then also pulling some of those people that are used to like the PowerPoint, pulling them into an escape room and really getting them to engage to help them learn or to help them teach others how to do it. So multimodal approach, you can really adjust any game that you can think of if you get a little creative you can make it into something that helps with that learning environment. So really kind of thinking about what games do you have out in the world, and how can you adjust them. And then always provide ongoing regular education. If it's sporadic, it gets lost. And so we do think that on the regular pieces of those education are very important. And then in the end, have fun. Make it fun, make it silly. You know, I'm definitely one that will make a fool out of myself if it engages the staff. And so we want to make sure that they're entertained a little bit so that they remember it. So we want to make sure that it's fun. So always have fun. So, and now we'll open it up for anybody that has any questions, if there was any questions in the chat.
All right, so if you are on the call and have a question, please type those in and I'll read a few that have come in so far. From AMVC's president, Alicia Richardson, she says, I hope you have been nominated for AMVC's Stroke Clinician of the Year for this work. This year's theme is creativity and innovation, and really what you have done here is a perfect example. Deadline is August 1st, so if you want to talk about that afterwards, I can assist with that. Next from Jamie Smith, excellent presentation. Our staff loves escape rooms, and Jamie is wondering if you'd be willing to share critical thinking exercise and assessment tests. Is that something that your group is able to share?
I think we can share pieces and parts of it. So what I can share that won't get me in trouble with HCA, I will definitely share. So, but
Thank
I
you,
think we
Leah.
can give you some. Yeah.
How did you find funding and get leadership support for the things that you've done?
So one of the nice things about neurology education is that we've kind of already put into place that they need those education hours for the certification of the hospital. And so we actually didn't really have to fight for funding at all, which I know that that is a piece that others will have to. It's kind of an uphill battle, but we had built-in education hours into the budget because we needed to maintain 8 hours of neuroeducation for our comprehensive stroke centers, or we had 4 hours of education for other our primary stroke centers. So we were actually able to utilize those hours for our funding. So that was helpful on our end. Sometimes we do have to adjust if the budget is really tight in a certain space. We might have to move our class to the next month or things like that. And so we really work with the leadership to make, or if we have like a big group of new hires coming in and we know it's going to be a big group of new hires, we'll kind of spread them out a little bit amongst the classes so it doesn't hit all the budget at once. But that really just comes into working really closely with the leaders. It did help for Lindsey and I that we worked as staff members for the leaders that we work with now as educators. And so they knew us, they knew what we were trying to accomplish. But just kind of giving them the goals. And then some of the leaders really need the data. And so we pulled the data of what our core measure looked like before and what our compliance looked like after, and how that class was helping those things, because that always speaks to people, those numbers. So we got kind of lucky on the budget aspect, but I will say that it's an open communication and you have to go from the top down. If you don't have the budget from the top, it's really hard to build it up the opposite way. So yeah, I hope that answers the question.
Do you give education hours for multidisciplinary round attendance?
If they attend regularly, we can. So we definitely do. So our therapy teams need to have a certain number of hours. And so if they are the representative for a certain amount of time, we'll definitely give them hours because they learn during those rounds. Our case management team we use for their education hours. And then the staff, depending on how often they work or how long they worked, because they're in there for we will give them a certain amount of time, but we do have to add it up. And so we have to make sure they've worked a certain number of shifts. We definitely gave them education time for the lunch and learns and attending those. So.
Can you describe how you set up the tracking system and HealthStream for hours that made it so much easier?
Sure. So we use HealthStream, and if you kind of know if you've seen HealthStream before, you can make a basically an assignment in HealthStream that becomes a list. And so what it looks like on the learner's end is they open it up and they have a checklist that says like 1 hour of stroke education here, 1 hour here, 1 hour here. And so every time they complete one of those hours, they're supposed to go in, they're supposed to type in what they did for that hour, and then they click that they completed it. And so it helps them track what hours they need for their assigned hours, whether it be 8 hours or 4 hours or 6 hours, whatever it is. But we assign it to them on January 1st, and then it's due on December 31st. So they have the whole year to complete it, but they can go back and look and see, oh, I need to do this number of hours before this month. And so if they do an hour's worth of rounds, they can type that in there and they can say, I did rounds every day in June. And that adds up the time, and then they complete it that way. And so that made it easy for us to run reports through HealthStream to see who had completed everything and who hadn't. And so we could really help them find educational opportunities if they were missing education as well.
That made a huge difference, I think, going on as we move forward. We've got two last questions. The first one wanted to know the stroke certification or the certifying body for HCA facilities, and I can answer that one. The question was, is it TJC or DNV? Well, in Continental, it's both.
Yep.
And then in a large part of HCA, it's more DNV than Joint Commission. And really, the education that you guys provide or the things that you're doing work for both. Would you agree?
Yeah, we try to actually take the more stringent of the two, depending on what it is. And sometimes it's DNV in a certain category that's more stringent, and sometimes it's Joint Commission. And so we take the more stringent of the two, and we actually incorporate that into our education plan so that everyone's covered. And so we try, and so we still standardize it out that way, but we do make sure that we're covering both certifying bodies.
And then in the health stream where you're tracking the 8 hours, are they responsible to add the description, or do they have to like upload certificates or something else that proves that they did the work?
So if it's something that is already tracked in HealthStream, so if they did a module in HealthStream, I just need them to put the title because the rest of the information is already there. If they attended a conference, we do have them upload their certificate to that conference just so that we can see it. But if it's something I already have access to, I don't make them upload it again. And so usually they're pretty good about that. They'll just say like HealthStream module and they'll give me the title, and then I can go find it if I need to.
Well, we're at the top of the hour. I want to thank both of you for speaking for ANVC today. Again, really great information and great work that you guys have done. I wholeheartedly agree that this would be very worthy of ANVC's Stroke Clinician of the Year award. For those of you that joined us late, attending today till the end gives you eligibility for continuing education. You'll receive an email from Arizona State University with an evaluation. Please fill out that evaluation. When you turn that in to ASU, then you will receive the certificate from the certifying body. All right, well, thanks everyone, and we'll see you on future webinars. Thank you.
Thank you.
Thanks.